Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. We're going to do yet another video about existing cases with implants. I think I have another one made previously if you want to watch the other ones, and even ones about prepping to get ready for a case that will have implants. You can go into my channel, Straightsmile Solutions, put in the keyword implants, and it should show up. So today we're going to talk a lot about why I don't like to take cases that already have implants placed, and certainly anterior implants are a much bigger issue than posterior implants. If it's just the implant and it hasn't been restored yet, it's less of an issue than if it's been restored, but it's still a problem. So here's and each case is a unique situation. Some you absolutely can't do. Some you might be able to do if you do certain things. And some are going to be a liability if you try to do them. And I just wouldn't touch them with a 10-foot pole. Now remember, my basic position is if you're dropping implants in, I don't care if you're a periodontist, an oral surgeon, a GP who does it, and you don't do the ortho first and your patient needs ortho, either for crowding, for bite, for whatever, unless they are like textbook perfect, if they could potentially be improved with ortho, I personally believe this is standard of care, that you either need to educate them or refer them out to an orthodontist to get educated and find out what the options are, how they could benefit from this before you drop any implant or restore any implant, because it is going to come back and hit you in the face if you don't. It doesn't matter if it's next year, next month, 5 years from now, 10 years from now, because I get a lot of doctors who get patients who just clearly needed ortho first. And, no one ever told me that I could have benefited and that this would have been better and my implant would be better and it would look better. No one ever told me that it's almost impossible for me to do ortho later after the implant's been placed, or it's going to significantly decrease the outcome. So this is where liability can come in. So if you don't have that in writing that the patient was educated, you want to get that letter. If you're not doing ortho yourself, you want to get that letter from that orthodontist and put it in the patient's file. Boom, they went, this is what they said. Patient turned it down. For that reason, we're placing the implant, but patient understands that there were other options and declined them. And if the orthodontist already explained what they were, they should be in the letter. If you did not get a letter, it's like it never happened. This is just like dentistry 101 in dental school. If it's not documented in writing, it did not happen. It doesn't mean you can just document it in your chart notes. There has to be some proof. And if you're the one that's doing the exam or the consult and offering the potential ortho, then you need to have your treatment plan. I don't mean just like an Invisalign plan hanging out, because eventually that's going to get archived. You better download something and archive something and put it in your practice management system and grab a signature from the patient saying, I was offered this, the cost was this, the benefits were this, the risks were this, and I declined it. I understand the risks to my outcome. Okay, that being said, I'm assuming you did all of this and you understand this before we move on. All right, now you're stuck. Patient comes in. It wasn't your patient. Some dum-dum put an implant in. Who knows if the patient was given options and turned it down or wasn't given options. At this point, that is irrelevant. Patient might be mad. Sometimes you can tell, sometimes you can't. What's done is done, right? So we're not going to throw doctor number one under the bus because we don't really know what happened, And so sorry if that's an issue. Patient got to go back and take it up with them. It's neither here nor there. You're moving on. We have a problem. Implant's already been placed and now patient wants ortho. So if it's a back teeth one, meh. It's usually not a huge issue. I definitely would love for you to go back and listen to my video. It's about crowding, and I always forget the title. It's something like Ways to Correct Crowding. If you literally just put in the keyword crowding into my channel with over 220 videos, 2,220 videos, 2,000, it will be the number one that comes up because I just checked. And it talks about the 5 main ways that we correct and address crowding. Watch that video first, because otherwise this is not going to make any sense, because you have to understand the 5 ways we correct crowding. Obviously, if we have an implant in the bone, there are certain ways we can't do anymore. We can't do sequential distalization. We're not going to do arch expansion because we can't expand this arch without also coordinating this arch, right? And we can't expand this arch or constrict it because there's an implant in the bone, right? So that basically leaves the front teeth. We can't do much of the back teeth. That's fine. We can lock the back teeth. That's not a problem. My personal preference, if it's a terminal tooth, is just to leave the implant uncovered, like it's not even part of the treatment. If it's an implant, I don't care, right? A regular tooth, you can't do that because it's gonna If you leave it uncovered, it's going to hyper erupt. Well, an implant's not going to hyper erupt, right? I don't even want a tray on it if I have a choice. And then I don't care, okay, yeah, we might have to do IPR. We might have to take a lower incisor because it's unlikely that we can just procline the heck away without changing the arch form, depending on the age of the patient. But because I don't even really want to have it covered, and a lot of this really depends on the aligner system you're using and the material they are and the trim line, because every time you take that aligner on and off and on and off and on and off, there is a movement that the implant is not designed to have multiple times a day, multiple days a week, multiple days in the year, thousands and thousands of times over the lifetime of the treatment. I could not find any research that backs this up. This is just from my personal, just common sense and preference, and also the way that dental boards work, the way that insurance companies especially work. They are going to say, well, why did you include it in the treatment plan, So in any case, I would rather just leave it not covered, leave it alone, not have it be part of the treatment. And if it's something like a ClearCorrect or one of these ones that has a higher trim line that's going to go down around, yeah, you can block it out, but is it really blocked out? It's still going to come on and off and on and off. So I'm just afraid that if the implant were to fail, hypothetically, during treatment, shortly thereafter treatment, even a few years after treatment, someone's going to go back and be like, well, there was ortho, and then they're going to try to pull your treatment plan and see if you moved it or see if it could have been moved or could have just been the on and off of the tray, and you might be sucked into a potential nightmare. And I've been enough of these potential nightmares where I had like releases and stuff like that, and no, did I get sued? No, but I had to give like ridiculous refunds. So and it was totally stupid. Sorry for that beeping. But in any case, that's just my thought. So this is going to be more difficult, right? Because it's here and there's this, so we can't cut the tray here because not tooth's going to hyper up. So you're going to have to include it. So you can always trim it, and whatever, or tell them to try to block it out as much as possible, but I still don't love it. So in cases like this, I would rather, if possible, just do upper treatment only. That would be my personal preference. Sometimes it's not possible. It depends on the complexity of the case. Otherwise, you better have some airtight informed consents. Maybe you work with your liability insurance. Maybe you work with an attorney. I don't know. It just kind of gives me the heebie-jeebies. I don't love doing that. An anterior case, forget it. You know what I mean? For every action, there's an equal and opposite reaction. I don't care. Even if you lock this tooth and you're only moving the ones around it, nah. So I don't love that. It's a lower only treatment. And I hate lower only treatments to begin with. They often don't work. And that means it's a lower only anterior treatment. We're locking all the back teeth. And that might not even be possible. It's just probably a no-go. Now, that being said, if you're including an implant in the plan, you better as heck be using either Invisalign or Spark or one of these plans that allows you to use a CBCT. So the CBCT is in the plan, so I can see the implant screw, I can see the implant crown, I can see everything that's going on under the bone with every Clin Check. So that is important because we need to make sure we're not running teeth into it, we're not moving roots into it, anything that could happen. I know I love to trust the software, but sometimes, especially when the patient is non-compliant, things happen that are unpredictable. So, and that means every single refinement you do, you need to do another CBCT. And if you don't have a CBCT, you have no business taking this case, in my opinion. Send it to someone who has the proper technology to handle this case. Again, just my opinion. Yeah, you could take a bazillion panos and PAs with a shift, and maybe you could deal with it that way. That makes me very nervous, but that's the old-fashioned way we used to do it. But I would rather just have it in the plan. If the technology's there, if you don't have it, then don't take this case. You don't have to take every single case that's out there. There's plenty of dentists and orthodontists who can take this case and do it properly. Another option is to take the crown off the implant. Now, obviously, I have never placed or restored an implant. Why? Because I'm an orthodontist, not interested. But my husband does them all the time, and I know lots of general dentists who do them, who do amazing work and do guided placement, and they're very high quality dentists that do work with oral surgeon and work with periodontists, and they don't take all the cases, just like I'd recommend that general dentists who do ortho don't take all the cases. They're going to refer the hard ones out. But I know if I remember correctly, some are screw retained, some are cement retained. If you're able to take that crown off and now we just have the implant in the bone, now that's a whole different story because we don't have to worry about teeth banging up against it. Yes, we have to worry about roots banging up against it. And yes, we still need to use the CBCT fixture. We still need to keep an eye on it. But at least we don't have to worry about what's going on above the bone. We only have to worry about what's going on below the bone, which just means you're taking the CBCT every few months and or a series of x-rays every few months just to keep an eye on it. We don't want this getting too close to that, right? But that's a slightly different story. And then it's great because then you can actually restore it later and make it look really nice. You can put a Pontic in the trays and they can be, you can slow down the trays so that they can wear it when they eat, and they can change their trays 2 or 3 times a week because you slowed it down. Instead of a 30 tray, it's a 90 tray, and they're changing it 2 to 3 times a week, and they're going extra duper slow. I have a lot of content about that, eating with trays in, whether you have an anterior Pontic or whatever. I'm totally fine with that. That's a whole different story if you can do that. Not all kind of patients are going to be okay with taking a perfectly good implant crown off in order to do ortho, but you know what? If that's the only solution, then that's the only solution. So that is pretty much my overhaul on implants. Again, I'm not an implant placer or restorer. So if you guys do implants and I've said something wrong or different or you disagree, this is just what I gather from doing implant places in ortho and the mistakes I've made and mistakes I've seen other people make and how I get around doing things and still getting a great outcome and trying to address the patient's chief complaint. Hopefully that helps you. All right, thanks.